Um, cool. Let's start.
Yeah.
Yeah. So I guess this is the first journal club we're having, and it's probably the first journal club I've done as well. So kind of just taking it on the fly here, but let's hope I'll try my best as possible to convey the whole picture of the paper to you. It's pretty close to what we are doing with a few of our projects. As Siddesh has mentioned, we are working on surgical database for India, which I'm involved in. We've just finished cleaning up the data set. So quite a few things resonated with the paper which we have right now. I hope you guys have at least had an opportunity to sort of go through the topic and what's going on in there. I am just going to start sharing my screen so we can have a discussion on. Hold on. Select multiple windows. Cool. Yeah, can you guys see it?
Yeah.
Okay. So our topic is it's a 2019 paper by Joseph Mena, which is titled as a spatial database of health facilities managed by the public health sector in sub-Saharan Africa. So essentially what's happening here is that it's slightly different from your normal type of paper where you usually have an intervention or some sort of research where they're comparing things and understanding significance or proving a thesis. But this is part of the Nature data, scientific data journal, which includes databases of healthcare significance, which can be used by everyone else or governing bodies, WHO, for healthcare planning and stuff like that. So these people have come, this paper essentially is telling you how they have managed to create this database, which did not exist before, right? So let's just let me just introduce why this paper is important, right? So this paper is telling you that they've created a database, and as we know, data is the new gold. So data is important for us to understand how we can most effectively optimize healthcare spendings and healthcare outcomes for patients in today's healthcare system. So essentially, if that is the case, then it becomes even more crucial for us to have a collective data set where you can compare and understand it and visualize it, and then think about policies. If you just go on the fly and say we're going to create 30,000 PHCs, we're going to create these many places, but don't understand exactly which areas would be best suited for placing them to allow best coverage, it becomes sort of a half-baked cake, right? That's not the optimum use of taxpayers' money and stuff like that. So that's just one of the examples of how it can be used, but that's why this sort of a data set or this type of a data set creation becomes important. Now, traditionally, usually healthcare facility analysis or data has been researched and understood. You've probably heard of this phrase where you say there's one hospital per 50,000, 1 lakh people, right? That is how you compare it. Number of facilities, the population of a place divided by the number of facilities, which gives you that number. But that is not an actual representation of if people are being covered by that hospital, because it does not give you an exact understanding of where these hospitals are. Colloquially speaking, you could just you guys can understand that most hospitals are placed within urban places, and therefore rural populations don't really have that kind of access to the hospitals which we talk about. So kind of that ratio which we talk about, that number of hospitals per this much population, is again a very incomplete data or incomplete way of conveying that message to people about how well the population is covered by healthcare facilities. So what these people have tried to do is that they have geo-referenced and they've created a comprehensive public health facility database for sub-Saharan Africa. Sub-Saharan Africa includes a set of 50 countries below the Sahara Desert, and they've used multiple different methods, which we're going to discuss what they've done, effectively creating an inventory of 98,745 public healthcare facilities. Now, just a basic background is that sub-Saharan Africa has been somewhat of an area of low data. It's been a low data source. So they've recently gone into digitalization. They haven't really worked on their systems. The different countries use different sort of systems. Countries are in different political turmoils, and therefore the health facilities is not something which has been looked after that well. So basically, what the countries have been urged to develop something which is called as health master facility list. This word will be used quite often in this research, so just have a note of it. Master facility lists are basically of a country which lists out all the hospitals which this country has, private or public, NGO, whatever, all of them on one single spreadsheet. If you can put it down, that is what would be called a master facility list, and their exact location and addresses. Although they can be of different types, so NGO, government, private, etc. And there's been a huge development in the private sector as well, which we'll discuss about in subsequently. But essentially what they're trying to say is that access to healthcare is quite multidimensional, and in the most basic sense, if you don't know where a hospital is, you cannot plan effectively for its development or the care you are trying to provide for a population of an area. So that is why they took up this research, to understand the geographic availability of hospitals rather than just the availability of hospitals. Now, this service is basically they've used quite a few different types of data sources and compiling softwares, but basically what they're trying to use this data for is that they can identify top tier hospitals and lower tier hospitals. It is now possible to estimate a specific access to emergency care and surgeries. So for example, let me give you an example. So from the Lancet Commission, they defined accessibility to the Olugunde paper, which tried to define geographic locations of healthcare facilities in Tanzania. They assumed a distance of 2 kilometers to or 20 minutes away from a hospital to be a good access to a healthcare facility. Now, if you can create a map around every hospital with that radius and you see the intersections, then the places where these are not intersecting are areas of deficit, which are outside of the defined metric of accessibility to healthcare facility in case of emergencies or emergency care. The other use which these people are trying to look at is extend the understanding of healthcare optimization. Like I said before, the use of public money in healthcare has always been undermined, and it's never been at a level which is expected of a country. That is why optimizing the money that you're putting into it becomes even more important. So like understanding, for example, if you can only afford to supply one hospital in a rural area with antivenom, how would you understand where to send that antivenom? How would you, where exactly would you send it? This is where the geographic understanding comes in. If you understand where sending it would cover the most amount of population, even though there are multiple hospitals in that area, but you can only supply one. If you can understand the geographic location, you can understand the most optimal place you can keep that medicine, therefore saving more number of lives compared to just randomly allocating it to some hospital in that area. So these are the two main uses which they're looking at, right? Now the methods that they've used, data sources, I think I'll just jump to the diagram that they have, which really explains it well. Their whole process for creating this database has been, first, they need to collect the data. They need to collect it from 50 odd countries, which is a huge feat, because that itself is really difficult, especially in countries which have not developed their IT sources, etc. So collecting the data sources as much as they could from primary government facilities like Ministry of Health websites was 50% of the 50% of the countries they were able to get it from the Ministry of Health. Then when they were not able to find it from the Ministry of Health perspective, they went into smaller ministries or state agencies within that country. Maybe they had uploaded something, they compiled it from there. So the second level was also from governmental agencies. They were not able to, or human data exchange databases, which have compiled a few countries' hospital data, which included 18% of it. When they were not even able to get that, they tried to look for other sources like NGOs which had compiled data, like faith-based organizations which had compiled data. That comprised of 14% of their data source. And lastly, when they were not able to get anything, they contacted renowned researchers within, say, for example, the National Malaria Program of that area, who had databases of where they were supplying medicines or where they were giving treatment, and that they compiled it through personal communication. So this was the hierarchy of how they tried to get the data. It was only through exclusion of these four would they come down to personal communication to find data for some place, right? Now, just collecting data is not is just the first step. The next step is understanding why you're collecting the data. So the rationale which they give is that they are trying to understand or create a database for facilities or hospitals which are using public money and are providing, and those hospitals are providing care to the general population. That is why they have excluded private facilities, although they have included private not-for-profit facilities, which they consider to be serving the general population without technically being a huge drain on resources. They have excluded specialized facilities like military, police, psychiatric hospitals, pediatric hospitals, maternity hospitals. Now, this is one of the caveats which I feel is a caveat in this study, because we in our study have considered maternity homes and pediatric homes because of the fact that even if they are maternity homes, they are still government maternity homes. Those if they're government maternity homes, then then it still becomes something which is serving the general population and using taxpayers' money, and therefore it should technically be considered. Even though it is for a special population, it does not exclude anybody from it per se because of their occupation. So I personally feel that they should have included pediatric, maternity, psychiatry, military, and police. You can understand that it is an exclusive hospital which is not serving the general population. But that is one of the caveats that I feel was there. And all the facilities which they deemed as were closed or under construction were excluded as well. Then they moved on to data cleaning. So quite commonly, data cleaning is the most tortuous process in any data set. You need to remove the duplicates. You need to remove name errors. You need to go through each of them. You need to understand name variations. So for example, one place could be named like public health PHC, and the other would be Samuhik, like it would be Samuhik Arogya Kendra, which is the Hindi version of the same facility. So you need to understand those variations as well, and you need to remove those. Missing information is added. For example, PIN codes are missing. You need to geolocate them and add PIN codes. Data reformatting, probably just to make it a little more even, make the data source uniform. Then they moved on to geocoding. Geocoding, what they did is basically coordinates from the original source were retained, or they coordinates from a digitalized map. Now, this is a bit of a hard concept to understand, but some places had digitalized maps, which were basically a representation of the data onto a map. The problem with that is that because they exist in this sort of a format, you do not get very specific data points. You get a visualization of the data, but data points is not there. Like in Excel, you get exact the number of your latitude, the number of your longitude, the pin code, etc. So what they had to do in this case was they used something as the GIS. GIS is basically Geographic Information System. It is a file format basically, and they converted those digital maps into GIS format, which basically GIS includes all types of data. So like, for example, if you have a location in GIS, it would include its latitude, longitude, altitude, its it can contain a breadth of geographic information, which can be used for a number of different things. So they used quite a few sources like Google Earth, GeoView info, and combination of all these methods. And after they had done this, they needed to verify that the data set that they had after all these four processes is actually correct. So they used something called as the Global Lakes and Wetland database, which basically understood if a facility was in the water, or for example, there's a lake there, and the exact geolocation which they have on the database is inside the water, it's obviously wrong, right? It's if it's outside of the boundary of a country, it's obviously wrong. So they used those databases to understand if any of the facilities they had marked on their data set were falling into those categories. They use Google Earth to verify, and some places they even did something which is where they were not able to verify that that place actually exists there. What they did is that they went on Google Earth, they found a population map of that area, and they if it was basically like that geolocation, and if it was actually populated around that area, it confirms that that is actually some an area where a hospital might exist. And that was sort of an indirect verification of the fact that this hospital actually exists here. But there was also a small caveat in that they only considered areas or villages which were less than 5 square kilometers in size to reduce the error rate. And eventually they calculated all the health facilities that they had, the types of health facilities that they had, and they compared them against the health sector strategic plans of every country, and they compared the numbers. So if, for example, the number that the government had stated that exist in the health sector strategic plans and the number that they had in the data source had to align together, and they aligned closely, which indicated that the number of facilities that they have is not overestimated or extremely underestimated, which kind of gave an indirect validation as well. This is just an explanation of all of that data abstraction, how it was done. And so basically the reason, like I mentioned, they excluded all these special places like maternity, pediatric and stuff, and they justified it by saying that the spatial location of these services is equally important for health system planning, but were not universally documented across national health facility listings. Our ambition was to provide a geo-coded inventory of operational facilities providing broad clinical care to general population. To be honest, I just feel like they were being lazy in this. This statement does not make much sense because, like I said, they are still for general population, maternity, and pediatric and stuff like that. So I don't know. Maybe the situation in Africa is different. Right. So the data cleaning, we've been through how they did it. The definition and all was, so they used all these data sources to verify or get any sort of information they could to kind of clean their data set and also verify it. Geocoding was used. So the most useful digital resource was GeoNames Digital Place Name Gazetteer. So this is a software. Google Earth or Maps and other digital place name gazetteers, including Entrica, Open Maps, and stuff like that. So they've used a variety of sources so that they can say that they have multi-source verification of a place. Now they have used something called as ArcGIS. I told you about GIS, which is basically a way of visualizing geographic locations. It can include multiple small bits of information about a single place. ArcGIS is basically the software which is created with the GIS format in mind by the Environmental System Research Institute. It's sort of what their whole research is based around, because this is where they compile all their data after they compile it in Excel. So for facilities that could not be geolocated using, they, like I said, they superimpose the population map onto the geolocation that they had for areas which are under 5 square kilometers to minimize location error. This map basically indicates all the locations that they were able to identify. The reds are hospitals and green are non-hospitals. Now, what are non-hospitals? According to the research, hospital is basically a tertiary care center which has all sort of facilities and stuff like that. Whereas non-hospitals might be primary health centers or healthcare centers, stuff like that. And basically something which provides primary care or non-specialized care. Now the data records are were stored in a format where the longitudes and latitudes were defined till the 4th decimal space. Now the thing about 4 decimal spaces of a latitude longitude is that gives you an accuracy of 5 to 10 meters, which is good enough for any research. And we have they have basically included the first level administrative division, but not the second level administrative division in their final data set, which basically means that, for example, if you are talking about South Africa, they have only included South Africa, the state within South Africa in which that hospital is, rather than the district in which it is. Now, this gives problems because this it reduces the resolution of the data set, and it's something which they say is rapidly changing, but I'm not quite sure why this decision was taken. It's not really I couldn't really grasp why this was happening. The other pertinent details like facility type, facility ownership were also left out, because the problem is that, for example, a healthcare facility in Kenya is not the same as the word healthcare facility in Sierra Leone. So that basically means that healthcare facility in Kenya might be able to do deliveries and stuff like that, whereas a healthcare facility in Sierra Leone was only there for dispensing medications and basic treatment and referral to higher center. So the nomenclature of the hospitals differed from country to country, and that's why that was not included in the final data set, which they have suggested that the countries come together and form a singular nomenclature, which is quite difficult, to be honest, in the African subcontinent. So technical validation, we've gone through it. They've used ArcGIS, where they had two data sets from different sources, and Google Earth inspection manually to confirm that the locations that they had were correct. And basically, service delivery levels and number of healthcare facilities, like I said, they kind of cross-referenced the national database with the database they had and confirmed that the data that they had were matching to a certain extent, and that kind of confirmed that the data they had come to as a conclusion was correct. And usage notes. So basically, they've said how to use the data that they've uploaded. It's basically what they want to essentially say is that accessibility on its own is not a guarantee that the services are available. So the place could be closed. There might not be a doctor. There might be no medicines at that point. There might not, even if it's a surgical facility, there may not be a surgical room available. Stuff like that. So this data. So this is where the whole Lancet Commission comes into picture. Let me just give you an idea about what surgical care means. So surgical care essentially means how do you tell that a person has access to surgical care? The definition of that is fourfold. First of all, the healthcare facility must be accessible to him by the definition which we talked about earlier. Next, the facility which he goes to, which is accessible to him, must be affordable to him, where basically if he does need some sort of surgery done or something like that, he does not incur a catastrophic health expenditure. If these two conditions are correct, then the facility which he goes to and is affordable needs to be safe. So for example, if they're conducting the surgery, it needs to be conducted in a safe manner with all the safety equipment available and with proper outcomes. Now, with all of these combined, there is all then you could probably say that this person has access to proper surgical healthcare, right? So all of these things need to come together. This study is only giving you one aspect of that thing, where you are able to identify if a person has access to surgical care or any healthcare in this case. So you could use this data to define the scope, service provision, laboratory capacity, or optimize the catchment population for healthcare providers, and therefore this kind of data should be prioritized in policy making and stuff like that, so that they could come up with better policies and better allocation of resources. So, like I said, it's just one piece of a huge puzzle. They've also kind of said that they would like for nations to create a uniform coding system for facility types, and that would give easier understanding throughout Africa of how health facility is distributed. And the reason they kind of left out private right at that point was because they started collecting data in 2004, and it took them quite a bit. And then at that point, private facilities were not such a major stakeholder in healthcare for people. So now that private have become a huge part of healthcare of people, they want to expand to private sort of a database. And at quite a few places, private hospitals in a lot of countries are providing vaccination programs through the government. So they are playing an increasing role in the in the service of healthcare to the general population as well. So hopefully they're saying they would probably update this data for private as well in the future, which would be a nice addition. And as always, they have mentioned one small caveat where we recognize that despite our best efforts, this data set is incomplete and will change over time. As such, we encourage readers to alert us by email. So if you guys find out any African random healthcare facility which is not on this data, mail them. Whew, that was long. So that's the paper overview. So as part of a journal club, I think the understanding is that once everybody's read it and sort of had a quick introduction, if anybody has any questions or criticisms to the paper or how it could have been better, stuff like that, that is what we should do. Is that right?
Shirish, would you like to take over before that?
Hi. So actually, I didn't get much time to actually praise the paper as a whole. I understood it better when Tanmay explained it, because the project that this paper is being presented as a reference for, I am completely alien to it. So regarding appraisal, how this can be appraised, Tanmay actually said many points regarding how they found lacunae in how this thing could have been made better. So I guess people who are more involved in the surgical care database can give in more insights on how they are doing a thing that is a bit different than what is being done in this study.
Right. I think we have people from surgical care, right?
Tanmay, I had a question.
Yeah.
No, it's more like just kind of thanks for going through the entire paper for us. It was very helpful. I want to know if there's anything specific for surgical care database as well as the Indo-Heal map people that this paper has done different, that they can take away from this, something positive about this paper, that something different from what we are doing.
Yeah. So since I'm also part of the surgical this thing, I realized quite a few things. So although the software aspect I don't quite fully understand, it took me quite a while to just wrap my head around this GIS platform understanding. But what I did really appreciate in this study was the innovative way of them problem solving when they couldn't identify healthcare facilities for an area. So for example, let me just show you an example. Where they were not able to find places, right? So like if you've noticed in data sets, quite often there's some places where the address is given, but the name of the hospital is not there. What type of facility is there? It's not there. But it's like ye gaon mein hai, ye kuch to hai ye gaon mein. So what happens in that case is that you don't know if it's a PHC, it's a CHC, it's a DH, what is it? So what these people have done is that they have really made use of a population map, and they have assumed that this address, if there is this sort of a population, say for example we have definitions that that 30 I forgot my PSM, basically 30,000 people ke liye one PHC hota hai, right?
Yeah. I think so.
So yeah, according to the definition of the number of people for a particular healthcare facility, if there is incomplete information about a particular healthcare facility, and you can relate that to a population diagram where you say ki ye jagah ka population is 25,000, 30,000, 35,000, and they have mentioned that there is a healthcare facility here, then it's probably a PHC rather than a DH. So they have sort of used an indirect logic in trying to close those gaps.
Yeah.
And you also use that population map for something where they have not been able to verify. Say, for example, there's a proper name is there, proper address is there, proper pin code is there, proper geocoding is also there. But you just can't, you've put it on all your databases like Google Earth, Google, these other softwares that they use, but none of those places have any listing of this place. So they unke database mein nahi hai ye. It's only on the database which you have. So then how do you verify that this is an actual place? What they have done in that case is that if the village is less than 5 square kilometers, they have, so that they have considered that as their level of error. So 5 square kilometers ka agar village hai, in that they have seen if the population is there for that type of facility to exist, and they have confirmed that agar itna population hai and this facility exists there, and this is matching with the population sort of a map, then this must be true with a pinch of salt. Although there is no direct visualization of it, with a pinch of salt we can rationally assume that this place does exist here.
Okay.
So that was the most interesting sort of innovative solution that I thought they had come across. What else? Other than that, I think it's very similar to what we are doing. To be honest, it's very similar. Yeah, that's why it's so relevant to us.
Are we mapping private facilities, or are we not? Are we excluding that?
We are mapping private facilities. Yes. So
challenges that you have come across, particularly in like geocoding in our projects I'm talking about.
Yeah. So well, the thing about private facilities is that it's just the private facilities are a dream to geocode, because almost every private facility in India has their name on Google Maps. So you just need to put the name of the Om Sai Clinic and Shevgaon, and you have it. It comes up, because private players in India take more effort in making their name known on the internet. So it's more difficult to find government facilities compared to private facilities. That is my take on. Right. That is my experience in the data sets that I've cleaned.
Okay, thanks.
Yeah, Tanmay, you mentioned that the four levels of how accessibility to healthcare can be assessed, and you told that here only one of them is being said कि मतलब कितना पास में है या कितना दूर में है, but वहाँ पे क्या है, like what is there in that place, and is the person able to afford that or not? That is not being covered. So how is our study covering that?
So the studies which we are doing are also looking at accessibility only. We have broken down the studies of we have active projects in all of them. We have projects in affordability, like catastrophic health expenditure ka project hai, which is going on. There is a project on safety. So basically, we're going through there is a data source, ABCE data source, which has data which we can extract to understand if they fit the WHO safety checklist. So that is one project which is going on. Then there is this accessibility project, which is the biggest, because you need to go through a huge data set for that. Basically, the fourth criteria, which I did not mention, is basically having surgical care in that hospital, which obviously, if you're looking at surgical facilities, then that is how we've excluded that data set. So
methodologically speaking, how exactly is this, like how exactly have we come up with this kind of methodologies? Like you guys referred to these kind of papers and then designed your studies?
Which methodology are you talking about? Are you talking about overall surgical access methodology, or the accessibility to surgical care as facilities?
You can explain about one single study at a time.
So yeah, so basically the overall thing where I told you that there are 4 criteria and each of them needs to be satisfied. The probability of each of them keeps reducing every time when you add one more criteria to it. So that comes from the Lancet Commission on Global Surgery. So they had defined the 4 criteria as what is important. And the first people to do that, I think practically do that, was Olugunde in Tanzania. So that is the landmark paper which we are referring to, but they did it on a very small scale. We are trying to do it on a national scale. So that is why we have broken it down into four criterias, where we're doing each of the four, rather three, and then we're going to make a bigger paper. My understanding is that then eventually the bigger paper would come around, which has all these three criterias. So together, so that would be a big paper.
Okay. So are we going to have like more sessions on understanding this particular aspect of like database generating part, like on methodological aspect of how we create this database, like on understanding each of the part as such, like how data cleaning is done, on how data extraction is done?
Okay. So how data abstraction is done, data cleaning. So it's actually fairly straightforward, to be honest.
Okay.
When you I can explain it to you in brief, quickly. So data sources, we've used Ministry of Health and stuff like that. So PMJ database, NIN database and stuff like that, which our governmental India mein hai. All those
Okay.
databases exist. So we don't have to go, we didn't have a problem at data source finding, because these people are looking at 50 countries, whereas we're looking at one country, and apna, our census is good. So we have a good data which is available on government facility websites. So
Okay.
that first part is done. Now data abstraction mein we had excluded, since we're doing surgical care, we excluded all the facilities. So when you download this data set, it also gives you what facilities are available at each of those hospitals or healthcare facilities. So
Okay.
we used a filter and we removed all of them which did not include the word surgical or or delivery services or stuff like that, dental services, accident services or trauma, orthopedic, stuff like that, which are surgically related. Only those we included in our data. So that was removed. Then we looked at then we just had data cleaning. So like I said, we have included maternity, pediatric and stuff like that, because we feel
Right.
that if it is an organization which is serving general population, then they should all be included. In fact, we have included police and military as well in our current data set. I'm not sure if after this we might have we might want to alter that, but we have included police and military as well, which form a very minuscule part of the data set. There's not too many. Then we come to data cleaning. So data cleaning is the huge elephant which you need to get out of the door. So it's we have 12,000 only entries only in PMJ, which we have spent a lot of time cleaning, and then NIN has approximately 1,000-2,000 more, and we have one more data source. So
Do you use any software to do that, or like how this is done?
it's actually very interesting. So it's a mixture of software and Excel, but mainly the thing we're going for is manual verification. So we have used software as well to uniform to make all the names uniform, sort of like capitalization of letters and all. We've used Python script and we've made them capitalization. But overall, the cleaning of the data and putting the address in a proper format where the street, then the village, then the district, then the state comes in that order, that needed some time. So all of that with proper spacing and stuff like that took a time. So variation mismatching, quite often you didn't have the proper geolocation. So the best part about PMJ is that the PMJ data comes with the address. So we
What is PMJ?
Sorry, PMJ is Prime Minister Jan Arogya Yojana. You probably heard of this. So like in government hospitals like KEM, they have the centers, they have counters where you can go and claim for this. You probably see it in internship and stuff like that. So yeah, not so soon. First, you guys need to go to college now first. So yeah, so basically the data set comes with proper detailed addresses, and we ran it through a geocoding software which gave us coordinates, but all coordinates are not correct. So two of them were negative coordinates, which effectively means that the address was the name was Shri Sai Star Hospital, but then the location was in California, USA. So we just so those are a few issues which we had to rectify. So there's quite a few things which come up when you start cleaning things. And then the problem is that when it comes to 12,000 places, right, you can't manually enter every place ka geolocation and confirm it against a name. So we're kind of working on a strategy where we can automate that to a certain extent. So we have a few things in process. Maybe we probably know exactly which way we're going down in a week or two. So that's done. Then basically, then it's just validation. Geocoding is basically the same part which I told you right now.
Yes.
Yeah, and then the validation is there where we need to use 2 data sources to validate the places. That we haven't really gone into that yet. I think I'm a bit statistically and technologically handicapped to think about that. I fucking hate statistics.
This is a really an like amazing project that you guys have. Like how much of this is a like integration with other sectors apart from like medical people? Like I definitely feel like many engineers etc. are involved.
So yeah, like I said, when we did the whole the capitalization thing, we used I think it was either Amir or it was Yogesh who did that code where they changed all the names to proper title case capitalization. And the solution which I told you about, reducing the manual work for geocode verification, these guys are working on it. So these guys are computer science undergrads in PICT. So these guys are the ones who gave us we suggested if this could be done, and they actually did it. And I never thought this could be done, and they just did it in like 2 weeks. So that hats off to them.
Okay, then. I have already spoken a lot.
Yeah, all the best for Confluence.
Yeah, thanks.
Hi, Tanmay, can you hear me?
Yeah.
Yeah. So I had this one question about, so see, like, you know that we are facing problem with verifying whether the geocoordinates that we obtained after running this data sets of hospital names through GPS, through
Yeah.
Google Maps, may or may not be correct. Like, even if it's not negative, like the negative ones are those which are surely wrong. But
Yeah.
even if they're not negative, we are not very sure about whether they are right or wrong, and that's why we are working around it. So, so did these people, like for the research paper and the geo coordinates that they got, were they like already prepared just of rectified geo coordinates from the government ministry or from any other source,
Right.
or did they also do the same thing? Yeah.
Sorry, I interrupted you.
So did they also face the same thing of correcting or rectifying the geo coordinates or checking through them?
So they haven't explicitly detailed how they've come around to the whole geolocation of every place, but they have this entire section of geocoding. So like even our data sources don't have geo coordinates in them. We have just put them through a geocoding software and got them from as far as I know, if I'm not wrong. So these people have also apparently used multiple sources to get geo coordinates for places. And I think looking at this, they have not, although they have not detailed it, I feel what they probably must have done is that they would have probably put all of that data through multiple different geocoding softwares and sort of put an overlap key. This facility across all the softwares that we put it through is giving the same geo coordinate, and therefore we have taken this. Whereas the places where there was discrepancy between softwares, they probably did a manual, but I have no way of verifying this. They have not mentioned the details of how they did it. So that's why I honestly can't answer exactly how they did it, but this kind of gives me the idea that maybe they did it like that, and maybe we could do that as well.
Okay, so if let's assume that what you are saying is right, that they actually run through multiple softwares to get to see whether, like, to decide which ones need to be manually checked. So is this something that we can do? Like either you can answer or anyone from the surgical group can answer. Like Is this kind of thing available for us? Do we have multiple softwares to check through our geo coordinates and make sure that they are right? So you can answer if you know, or anyone else.
I mean, I've personally not used geocoding software, so I think I'm not the right person to answer this. Sorry.
So I think Amir and Aryan are on the call. Amir is on the call. Yeah, both of them are on the call. Siddesh is also on the call. So maybe can you guys put some light on this?
So apart from Google Maps, I haven't used any software, but
So
I
yeah,
think
go.
Siddesh knows more about this. Like we can, like apart from Google Maps, I think GIS, we can use GIS. I'm not sure.
Okay.
Isn't GIS just a visualization sort of a platform where you enter the details and it just gives you a visualization of it, rather than an independent data source?
No, then I think like OpenStreetMaps or Google Maps is the best way to do it.
They've said something about GeoView Info, Encarta, and they've given
No,
them.
I haven't heard about these softwares.
So yeah, I think Shweta, now that I see this, so they say that coordinates from original source retained 48%, which basically means that probably 48% of the places which they collected info from the data source, which is Health Ministry and other stuff, they had geolocations already.
Location. So yeah, so it's
Yeah.
like the ones that we got for vaccination private centers directly from government website. So it would be something like that. And
Yeah.
so 48% they got the geo coordinates like already from the ministry website. For rest of the 52, they worked around in certain ways, right? Yeah. So so about that, Aryan, like is it like there are not any of the other ways to geomap, like geolocate these that you don't know of, or you know certain ways but you do not know how to operate them or how to use them, or what's the logistic behind it, like?
So as you said, these are some tools that Tanmay mentioned, but we haven't actually used them. And for checking whether those geo coordinates are correct or not would come under, I guess, the technical validation part, which is to the right of that in the diagram.
Mm-hmm.
So using those data sets or those methods, we could check if it's correct or not.
Where's that? Okay, that part. Okay. Okay, I have no idea what all this is. Cool. So let's see, like let's discuss in detail about technical validation in the surgical geocoding call and see what we can use and if there anything that can be done or taken from this paper to apply on our data set. Yeah.
Yeah. Anybody else has any questions or criticisms to the paper?
I'm not sure if this would be, I mean, I think it would come under criticism, but I thought that this paper could mention or define the services that these public health facilities provided.
So yeah, so sorry.
Or did I miss it? Like I mean, as much as I.
So basically, these the data sources where they got it from, right? They also, the data sources did have details of what type of facilities which are provided. Some of them had it, some of them did not. And essentially the problem which I did talk about, where say for example, PHC might mean something else in Sierra Leone and something else in Kenya. The kind of facilities that they provide in them might be different. So that is why what they have done is that they have only classified between hospital, which they define as a tertiary care center, and a non-hospital, which is below the tertiary care center. So that is how they have sort of made the whole data uniform in that bifurcation, since they did not have an understanding, a complete understanding of which sort of facility provides what, and the nomenclature difference.
Right. Okay. I feel like that could also be probably the reasons why they excluded maternity and pediatrics and psychiatric facility, because they cater to a very specific service. That could be a reason why they would have excluded that.
Yeah, that is their rationale. Yeah, absolutely. That is their rationale, that they have left out maternity and all that stuff because it caters to a specific population. But then it's like, if it's using public money, it should be in your study. That's what I feel. Since they defined that it is for they're looking at health services database for basically which are providing for the general population. That is their core of their definition of selection criteria, general population. So a poor lady is still part of the general population even if she's pregnant. So why is that excluded?
If anybody have anything else to discuss, point out, please feel free to unmute yourself and talk. This is a JC, just can't be just done by presenting a paper. Okay. I don't see anything in the chat box either. Shirish, did you want to say something?
Yeah, while designing our study, have we referred to any other similar kind of a study apart from this, and we have improvised on that, or have we combined different methodologies on like while designing our own study, or was this the basic skeleton on which we designed?
So I'm not to be honest, I'm not completely sure if we have referred to other studies while designing our study. But basically, I think it started off with Siddesh having the vision that we wanted a proper mapping of healthcare facilities on a district level resolution, at least. So that was the vision which we started with, and I think we are still on that vision. This is something very similar to what we're doing, but to be honest, I cannot
So
comment
while
on.
designing the study, you guys did not have a basic skeleton or like existing, like ऐसा map already कहीं exist कर रहा है, let's create something similar here. Was it the case, or you Siddesh imagined?
I think Siddesh will be the best person to answer this.
Siddesh?
Hello.
Yeah.
I'm not sure. I guess Siddesh is having some problem with
Hi.
audio. Huh, okay.
Hi, can you hear me now?
Yeah.
Great. Sorry, I kind of missed that in between. Shirish, can you repeat the question?
Yeah, sure. So basically, I was telling कि while designing a study, like, did we have a basic skeleton of what kind of study we wanted to design based on existing databases, or this thing just ऐसा wonderfully happened कि हमने कुछ similar design किया और ऐसा कुछ already बाकी database में exist करते हैं?
Well, I mean, kind of in between those two things. So first thing is that we were following a certain protocol to create a database. I didn't know about this article when we started that, but looks like this article is also like following the same way. which is kind of pretty standard way for the geo databases. So
Okay, so there is a standard way on how to design.
yeah, I mean, like there are no as a prescribed guidelines as such, but people have developed ways of how to curate these databases and how to describe them. uh, I'm not sure if we are like if we are at a if like the total field is at a stage where like where they feel the need to prescribe guidelines, but like I'm sure in maybe next few years, or maybe there is a new set of guidelines that I'm not aware of. But as far as I know, right now there are no guidelines about it.
So are we going to refer to any more few papers on this kind of data sets to like look at a few more kind of designs through which we can like improvise on what we are actually looking at?
We can. Like the only downside to that is first it's unlikely that we would find anything new. Okay. Given that this is a more recent paper, right? This was published in 2019, I guess.
True.
So like usually the more recent papers try to cover, in terms of methods, they try to put up their methods in a way that it's exhaustive of the past, right? Like that's what any new paper tries to do. So that's one thing. Second thing, with respect to creation of the database, I'm not sure even if we find anything new, if we'll be able to incorporate it into our work at this stage, right?
Right.
Because yeah, I mean, this is like a lot of laborious and a lot of hard work done very diligently until now, right? So
Yes, absolutely.
adding like an abrupt step now will make things very tricky. What we can do though is if we find something which we haven't done, we can definitely but we think it is important, and in our case we can mention it as a limitation or as a consideration that readers should have while understanding our results.
Absolutely. Awesome. Great.
Yeah. Wait, Tanmay, like, do you want to add anything? Did that make sense?
Yeah, absolutely. Cool.
Okay. All right. Does anybody else want to ask any questions?
I just want to add one quick thing. If like I think, yeah, we kind of covered it, but still just want to, I guess, emphasize it one more time. Data descriptor papers are becoming very popular in general in like scientific, health, medicine, whatever world, because it's not only about you having a paper, it's also about you providing a very valuable resource to the entire community, right? I mean, for instance, look at this paper. The data set that they provide with, like, the paper is basically secondary in these cases. It's just describing how they came up with the data set. But the data that they provide, it has already been cited multiple times till now, uh, within like last 1.5 2 years, and I'm sure that it's going to help a lot of good researchers working in sub-Saharan Africa, a lot of good policymakers who want to try very targeted spatial interventions and those kinds of things. So like putting out a data descriptor paper is very intimately connected to what ASR as a group is trying to do. That what we are trying to do is provide high quality data, high quality insights that others can then use and in their own work, right? So that's why I mean, it is an important project. It is also a very personal project for me, since it's connected to like my area of interest and thesis. But apart from all those things, it's going to be a very valuable resource that will create a lot of momentum and citations even in the research. So yeah, just kind of wanted to, I guess, hamper on that a little bit.
Hello.
Uh, well, okay, Siddesh, I think, are you done? It suddenly stopped.
Nini, that's all. That's all. I
Okay.
kind of wanted to just say.
All right. Okay. Thank
Atmika, I think your mic is.
Sorry. Yeah, this was great. Thanks. This I think was really good, JC. And Shirish, would you like to add anything? Like probably we can do something better for the next JC or
Yeah, surely. Like, I actually wanted to have a meeting post this JC because, like, uh, we can streamline a bit more on the process as well as like on like what I would say is making the content more relevant to the audience and increasing more audience participation because today like not I don't think many people might have read this paper जैसे and even I did not understand it पहले and the way it was put forward पहले से कि okay this is a JC happening and this things would be covered आई गेस ये अगर एक प्रॉपर मेथोडोलॉजिकल एस्पेक्ट है तो इसका एसएलओ पहले से डिसाइड करके ऑन व्हाई वी विल बी डिस्कसिंग दिस विल बी कैन बी डिस्कस थोड़ा पहले कि लाइक दिस इज द मेथोडोलॉजी दैट वी आर फोकसिंग ऑन एंड सो इस मेथोडोलॉजी के रिलेटेड हम और पेपर्स पढ़ के आ सकते हैं सो दैट वी कैन